So welcome to this new ERKNet webinar. My name is Francesco Emma. I'm speaking from my office in Rome. As always, let me simply remind you that your microphones are turned off, but that during and after the webinar, you can send your question through the GoToWebinar application that appear on your screen. I will ask your questions at the end of the presentation. The webinar will last approximately 35-40 minutes, and we will have hopefully 15 minutes available for questions. So our speakers today are Stefan Kohl and Valentina Capone. Stefan has graduated from the University of Freiburg in Germany and has performed his PhD in the lab of Professor Walz and Professor Huber on the role of MAP1B in podocyte. He has then made a postdoc, 2.5-year postdoc in Professor Hildebrand Laboratory in Boston, focusing on monogenic Kakut and genetic forms of nephrotic syndrome. He is now board certified in pediatrics and pediatric nephrology, and his current research interest lies in Kakut, genetic kidney diseases, and nephrotic syndrome. Valentina, on the other hand, has graduated from the Piemonte Orientale University in Novara, Italy, and she has specialized in nephrology at the University of Milano. She's been a postdoc in the Division of Nephrology at Columbia University for 1.5 years, and since 2017, she works in the Pediatric Nephrology Division of the Ospedale Maggiore in Milano. She also has a specific interest in Kakut. So the title of their presentation today is Dysplasia and LUTO Guidelines. Please, Stefan first.
Okay, can everybody hear me all right? I hope. Okay, dear Francesco, Emma, dear colleagues, I'm actually very happy to present our consensus project on kidney dysplasia on behalf of the ERKNet working group on kidney malformations today. Let's see if I can advance my slide. Yes, okay. So there are at least two kinds of kidney dysplasia. There is primary kidney dysplasia that results from intrinsic defects in nephrogenesis, and there is secondary kidney dysplasia that results from severe obstructions of the urinary tract. An example of secondary kidney dysplasia is lower urinary tract obstruction, LUTO, which will be Valentina's topic today. I am going to focus on non-obstructive dysplasia, although in clinical life, things are less black and white. We often encounter dysplasia with mild dilatation of the urinary tract or reflux. And in our current understanding, this form of kidney dysplasia likely is also intrinsic dysplasia with co-occurring other phenotypes of the Kakut spectrum. All forms of bilateral kidney dysplasia are very important for pediatric nephrology, as they represent the most frequent cause for chronic kidney failure in children. And given this importance, we were all surprised when Giovanni Montini et al. Showed us that not even experts in pediatric nephrologies agreed on how to diagnose this condition. So, as ERKNet working group on kidney malformations, we searched the literature on kidney dysplasia, discussed relevant studies in sub-working groups, and elaborated 30 statements on pathology, basic science, imaging, clinical management, and genetics. All statements were consented by the Delphi method and at ERKNet and ESPN meetings. In this webinar, we are going to review some helpful background information on non-obstructive kidney dysplasia, and then focus on imaging, clinical management, and a little bit of genetics. To get started, I would like to ask the audience, or all of you, the following question. How many patients with bilateral kidney dysplasia do you currently treat? Stephanie, can we have the poll question? please. Okay.
So I give another 10 seconds.
Oh, I think.
I close now. Can you see the result?
Yes, I can see them. Okay, I can see you didn't have none as an option. That would have been interesting, but it doesn't matter. So thank you very much, all of you. So I take it from the results that most of you have encountered bilateral kidney dysplasia, and some of you even quite frequently. Okay, thank you very much. So let's review some relevant epidemiologic data on how common kidney dysplasia is and what morbidity does it cause. Okay, so Capone and heart defects represent the most frequent groups of malformations in humans. 1 in 100 children is born with Capone, and about 1 in 2,000 children with kidney aplasia, dysplasia, or hypoplasia. I like this table here by Harambat et al. Because it summarizes several relevant epidemiologic studies on kidney diseases in children. On the left half of the table, you can see 3 cohorts with chronic kidney disease, with one of them being the large Nephrologist registry. On the right half, you can see 4 cohorts with children with chronic kidney failure. In all cohorts, Capone and particularly kidney dysplasia account for about 50% of pediatric CKD. When we look at children with chronic kidney failure, the numbers are slightly smaller. This is because the few children with glomerulopathies progress to chronic kidney failure more rapidly than Capone's. Kidney dysplasia can lead to kidney failure at any age. 50% of children will be on kidney replacement therapy before they are 6 years old. Boys with posterior urethral valves are at highest risk for chronic kidney failure in the first year of life. However, some patients with kidney dysplasia or Capone in general reach CKD5 in adulthood, as Elkevue et al. Have shown in their 2013 C. Jason paper. So what exactly is kidney dysplasia and how should we treat affected children? As we all know, the term dysplasia is a histological diagnosis. Principally, kidney dysplasia results from a derailment of normal nephrogenesis, which leads to failure to form proper nephrons, an abnormal histology, an abnormal kidney architecture, and also, of course, an abnormal function. Please note that primary kidney dysplasia is a malformation, but dysplastic kidneys also degenerate. This explains why many children with kidney dysplasia reach CKD5 when they are young, but principally at any age, as I've shown you on the previous slide. So, can we diagnose kidney dysplasia based on ultrasound criteria? And if yes, what ultrasound criteria should we apply? Unfortunately, there are no studies correlating sonographic findings of kidney dysplasia with post-nephrectomy or post-mortem pathology. So we don't have direct evidence what kidney dysplasia looks like in sonography. However, we now have consensus that 2 sonographic parameters are accepted to diagnose kidney dysplasia, namely reduced corticomedullary differentiation and diffuse cortical thinning. All other abnormal findings, for example, increased echogenicity, small size of the kidneys, or presence of cysts, they all may matter as well, but they should not be used for the diagnosis of kidney dysplasia. Furthermore, we also recommend to not use the term hypodysplasia anymore, because it really adds to the confusion, and it suggests that dys and hypo are equally relevant for prognosis, which we think they are not. So please, everybody, here's your take-home message. Kidney dysplasia is sonographically defined by reduced or absent corticomedullary differentiation and or diffuse cortical thinning. Let's imagine we are counseling parents with a child with kidney dysplasia for the first time. What can we use to roughly estimate the child's prognosis? Certainly, we can use the GFR, decline over time, that under stable conditions can be extrapolated. Additionally, especially in the very beginning, we can also use ultrasound findings to estimate a relative increase or decrease in kidney replacement therapy risk. To that end, we drafted a flow chart for sonographic evaluation of dysplastic and hypoplastic kidneys. For the sake of time, I don't want to go into detail here. However, please keep in mind that this is based on expert opinion, since available CKD registries do not differentiate between dyplasias and certainly not between sonographic subgroups. Still, you might find this helpful for your clinical work. We would like to be able to phenotype dysplastic kidneys more accurately by sonography. Therefore, I would like to promote this idea of sonotyping. We discussed this with Michael Schroeder at the ERKNet meeting for this project in Heidelberg just before the corona pandemic. Actually, this is very simple. Here I put it in an A, B, C through F scheme. And as you can see, most parameters should be in your routine ultrasound anyway, your kidney ultrasound. However, now comes the work part. We need to record the whole data set for the left kidney and the right kidney systematically, as you can see here on the right. A kidney sonotype contains clean data that can feed research and help us learn about different subgroups of kidney dysplasia. We are currently working on implementing this sonotype idea in the ERKNet registry. So hopefully in the future we will be able to treat our patients in a more personalized approach beyond CKD treatment. Once we have established the diagnosis, what additional things should we look for? Foremost, we need to make triple sure whether the contralateral kidney has Capone as well or not. In bilateral disease, especially bilateral dysplasia, we need to follow these patients more closely. The baseline eGFR is by far the most important prognostic marker we have. Keep in mind that your patient could have monogenic Capone with subtle syndromic involvement, so we need to look for that. In the absence of urinary tract dilatations or urinary tract infections, a VCUG or scintigraphy are not routinely required. Genetic testing is helpful in selected cases, as I will show you on the next slide. Therapy focuses on preventing the progression of CKD. Treatment of CKD in children with kidney dysplasia is not different from treatment of CKD due to any other causes. In short, we need to treat all risk factors for progression: microalbuminuria, hypertension, all complications of chronic kidney disease, and avoid urinary tract infections and other additional kidney injuries. And of course, if necessary, we provide kidney replacement therapy. Genetic testing in monogenic Capone or dysplasia in this case may be helpful in selected cases, even though less than 5% of all Capone are monogenic. In selected cohorts, however, 20% or even more of Capone are monogenic. That is why we recommend genetic testing in severe, familial, or syndromic Capone. Diagnostic genetic testing in LUTO has a very low yield and thus is not recommended. We suggest testing by whole exome sequencing with in silico filtered kidney panels and genome-wide CNV analysis. Generally, genetics cannot differentiate between kidney dysplasia or hypoplasia or any other isolated CACUT because identical genotypes can cause all of these phenotypes. Keep in mind that genetic testing and counseling in CACUT is challenging because of variable expressivity, incomplete penetrance, and also debatable CACUT genes. My last slide will briefly touch prenatal counseling because this was an issue of discussion in our working group. Generally, we should acknowledge that in any inborn kidney disease, except bilateral agenesis, the postnatal course of kidney function cannot be predicted accurately. So we need to think and speak in terms of more likely or less likely. We need to repeatedly re-evaluate throughout pregnancy as things may change. Amniotic fluid volume and lung size are predictors of possible respiratory complications in the postnatal period. We do not recommend prenatal testing for variants in CACUT genes. However, in syndromic CACUT, consider prenatal genetic testing for chromosomal aberrations. Okay, I would like to thank the ERKNet community and the ERKNet team and the ESPN for great support, and thank you also to Lutz Weber, to Max Liebau, and all my dear colleagues in Cologne, and of course to all of you for your attention. Thank you very much.
Thank you, Stefan. And now it's to Valentina.
Thank you. I hope you hear me and can see my screen.
Yes.
Okay, perfect. Thank you. Good afternoon, and thank you for inviting me. Today, I will present the results of the ERKNet consensus statement on fetal LUTO. First of all, a little introduction about LUTO, what LUTO is. LUTO is fetal lower urinary tract obstruction, so an obstruction of the flow of urine from fetal bladder. It affects 2 to 3 out of 10,000 fetuses, with a diagnosis that can be made either prenatally or postnatally with a 1-to-1 ratio. The most common causes of LUTO are posterior urethral valves and urethral atresia, while other less common causes are anterior urethral valves, megalouretra, cloacal malformation, and prolapsing urethrocoel. The consequences of LUTO are progressive bladder dilation and bladder wall thickening, with subsequent hydroureteronephrosis and kidney parenchymal compression. There is also a decreased amniotic fluid production, leading to oligo and anhydramnios. Oligo and anhydramnios are responsible for lung hypoplasia, especially when they develop during the so-called canalicular phase, between 16 and 26 weeks of gestation. Anhydramnios is responsible for the 60–80% of mortality if diagnosed in the second trimester of gestation, with a lifetime risk of developing end-stage kidney disease described in literature as about 30%. As already said, kidney damage in LUTO can be either due to direct compression on kidney parenchyma, but also can be due to gene mutations. And in this case, the same gene mutation is both responsible for kidney dysplasia and for the obstruction. There is currently a lack of guidelines on fetal LUTO regarding diagnostic features, differential diagnosis among different kinds of LUTOs, and also between LUTO and non-obstructive malformation, especially VUR, about the prediction of postnatal outcome in terms of survival and kidney function, and also about the benefits and limits of fetal intervention. This is why, at the end of 2018, the ERKNet Working Group on CACUT and obstructive uropathy decided to draft a consensus and write recommendations about the definition, diagnosis, and management of fetal LUTO that was published at the beginning of last year, 2022. The first topic treated in the consensus was prenatal diagnosis. Usually, the first sign, ultrasonographic sign of obstruction of the urinary tract is the presence of unilateral or bilateral hydronephrosis. The recommendation by the consensus was to use the UTD classification system for hydronephrosis. This classification, published in 2014, uses the APD, so the anteroposterior diameter of the renal pelvis, to identify those fetuses at increased risk for areal obstruction of the urinary tract. The APD must be greater than 7 millimeters between 16 and 27 weeks and greater than 10 millimeters after 28 weeks. Then there is the first poll question about what prenatal ultrasonographic feature is more suggestive of a lower urinary tract obstruction. I don't know if you see the poll. Okay. So here the answers can be bilateral hydronephrosis, anhydramnios, enlarged bladder, and kidney cysts. Okay, I don't know, I don't see the results. If it's done, yes. Okay, so the answer here, the most common answer is bilateral hydronephrosis, then enlarged bladder with a 50% of anhydramnios and a 2% of kidney cysts. Actually, distinguishing between an upper and a lower urinary tract obstruction, the most important parameter at ultrasonography is the presence of a megacystis, so of an enlarged bladder. The definition of megacystis, it's easier during the first trimester of gestation because it's defined as a longitudinal bladder diameter greater than 7 millimeters, with a likelihood of spontaneous resolving in 7 when the diameter is between 7 and 12 millimeters, and a high probability of LUTO if the bladder is diameter is greater than 15 millimeters. On the other hand, during the second and third trimester of gestation, megacystis is defined as a bladder that fails to void over a 40 minutes observation on ultrasonography. Megabladder, megacystis, is also part of the so-called classical triad of definition of LUTO, along with the Kohl sign of, as we can see here, of enlarged urethra and with bilateral hydronephrosis. This classical triad was also compared to a score published in 2018 and tested in 143 fetuses with megacystis after 18 weeks of gestation. This score that uses megacystis, bilateral hydronephrosis, the presence of oligo or anhydramnios, male fetal sex, and a referral before 28 weeks, seem to outperform the classical triad in the diagnosis of LUTO versus a non-obstructive megacystis, and for sure could be a very important and useful score if validated in larger studies. So the recommendations from the consensus here are to use the APD diameter of renal pelvis for suspecting the presence of an obstructive uropathy, but also to identify megacystis if in the suspect of a lower urinary tract obstruction. Underline also that megacystis definition has to be redefined during the second and third trimester of gestation. The second topic was outcome prediction in terms of survival and kidney function. We have already said that anhydramnios is crucial for lung development. And we can see that from this study from 2011 that the gestational age of oligohydramnios is statistically significant, significantly related to neonatal death. In this study, fetuses who died were diagnosed with anhydramnios at 28 weeks, compared to those alive who were diagnosed later during gestation. This is the second poll question. So we said that anhydramnios is important for outcome prediction for survival, but what is the most reliable predictor of postnatal kidney function? Anhydramnios before 20 weeks, fetal blood beta-2 microglobulin, fetal urine beta-2 microglobulin, or kidney dysplasia. Okay, so here we have a 54% of anhydramnios, 30% of kidney dysplasia, an 11% for fetal urine beta-2 microglobulin, and a 5% for fetal blood beta-2 microglobulin. So we go, before giving you the answer, I'll go through the various features. So from this study from 2009, we can see that oligohydramnios and renal cortical appearance have a very low sensitivity of respectively 63 and 57% in predicting poor postnatal renal function in fetuses with LUTO. So many biomarkers have been studied in the last few years, trying to find a good predictor of kidney function. The most studied was beta-2 microglobulin. For example, in a study from 2017, it was sampled from fetal blood twice during gestation, earlier in the first sample and at 33 weeks in the second, in 42 fetuses with LUTO. And the results from this study show that the last sample of beta-2 microglobulin have a very high sensitivity of 96% in predicting kidney function postnatally. Also higher than the prediction of amniotic fluid volume. Beta-2 microglobulin is commonly used because it does not cross the placenta, it's not cleared by the mother, so can theoretically be a very good kidney function marker. The pitfall here is that beta-2 microglobulin in different studies has very different cutoffs. So it's complicated to apply it in clinical practice. So the answer here is that so far none of the above is the correct answer, and there are no reliable predictors of postnatal kidney function. The recommendations here are that the risk of fetal and neonatal death has to be based on the presence of oligo or anhydramnios before 20 weeks of gestation, but also that the risk of kidney replacement therapy cannot be foreseen before birth, as amniotic fluid volume, kidney parenchymal echogenicity, and fetal urine biomarkers are not reliable predictors. Then the consensus discussed the developing of a staging system of severity for LUTO. In literature, there are two different staging systems. The first one was published in 2016 by Ruano. It is a bit complicated because it uses as markers the amount of amniotic fluid, the echogenicity of fetal kidneys, the presence of cortical cysts and cortical renal dysplasia, and three different and consecutive evaluations of fetal urinary biomarkers. The stage 1 of mild LUTO have normal amniotic fluid, normal kidneys, and good fetal biomarker. And in the study, they all survived with no risk of end-stage kidney disease at 6 months. Stage 3 of LUTO, very severe LUTO, had usually anhydramnios, abnormal kidneys, and fetal urinary biochemistry. In the study, they were not treated surgically before birth, and only 14% of cases survived, with a 100% risk of end-stage kidney disease at 6 months. The intermediate stage of severity with oligo or anhydramnios, but good fetal urinary biochemistry and a better aspect of the kidneys at ultrasonography, were all treated with vesicoamniotic shunting before birth. They survived in 75% of cases with a risk of the stage kidney disease at 6 months of 33%. So the authors conclude in the study that maybe this stage, number 2, second stage of severity, could be the one who could benefit the most from a prenatal intervention. The second staging system was published in 2019 by Fontanella. It's much simpler than the first one, and defines mild LUTO as a LUTO with a normal amniotic fluid volume at 26 weeks. Severe LUTO as a LUTO with a big bladder volume and or oligo or anhydramnios before 20 weeks. And moderate LUTO at the intermediate stage. In this severity staging, of course, the outcome was very different in the 3 stages in terms of perinatal mortality and impaired renal function. About staging of severity, the recommendation is that a multi-parameter scoring system to stage LUTO could be very, very important for selecting cases to undergo surgical management prenatally, but this staging system have not been clinically adopted yet because they need further validation to be adopted. Fetal surgical management, we have already seen that can change the outcome of fetal LUTO. The most commonly used approach is vesicoamniotic shunting. This approach means that a shunt is placed between the bladder of the fetus and the amniotic fluid cavity to try to bypass the obstruction and to restore the amniotic fluid. It's usually performed between 20 and 26 weeks of gestation and has a complications rate of 40%. There are 9 different studies who try to analyze the effectiveness of vesicoamniotic shunting compared to the conservative management. And they were all analyzed in a meta-analysis published in 2017 that includes 246 fetuses who underwent VAS between 20 and 27 weeks versus conservative management with up to 2 years of follow-up. This meta-analysis concludes that VAS is effective on perinatal survival at 6 months compared to conservative management, but it's not effective on survival of the child between 6 and 12 months, and also it's not effective on postnatal kidney function. Another surgical approach that is used but less used than VAS is cystoscopic laser ablation of PUVs, of posterior urethral valves. Also, this approach was studied in a meta-analysis of 4 studies and 63 fetuses, and the results here are that laser ablation is effective on perinatal survival compared to conservative management, but it's not more effective than VAS, than vesicoamniotic shunting of perinatal survival. So the conclusion here is that vesicoamniotic shunting is effective on perinatal survival, so it should be offered to parents in selected cases, but parents should also be made aware of the residual risk of long-term mortality and kidney function impairment. In conclusion, prenatal diagnosis, severity assessment, and management of LUTO are very challenging because there is currently a lack of specific diagnostic features that can help the clinician in diagnosis and decisions. Fetuses with prenatal megacystis need to be referred to an expert tertiary obstetric center. And if prenatal treatment is indicated, parents must be informed about the potential benefit for survival, but also about the residual risk of postnatal kidney function. Further studies are of course needed to improve the standardization for diagnostic parameters, prenatal biomarkers, and to improve staging system to optimize prenatal care. Thank you.
Thank you both for these very nice presentations. I think you really illustrate us some very important key aspects of handling of CACUT and highlighted some questions that have been around the community for many years, and we are glad to see that they have been debated and that for many of them a consensus has been found. So again, thank you. It was very clear. And so please, now you can send in your questions. So use the app and I will read your questions. So the first question, Dr. Abdelhamid Ramadan is asking whether prophylactic antibiotic can help in delaying CKD progression in CACUT. So who wants to answer that?
Stefan, if you want, I can answer.
Well, maybe I can. You can tell for the LUTO part. I would say for the general dysplasia and CACUT part, no, because I think urinary tract infections are not the main cause of degeneration of kidney function. I said that in my talk as well. We think that the GFR problems are there already. So those are primary dysplasia problems, and urinary tract infections don't really change that a whole lot. So I would say antibiotics cannot change the fate of dysplastic kidneys. Of course, however, they can change the clinical course. They can avoid infections and morbidity. So yeah, that's my answer.
Yeah, for LUTO, the answer is the same, because usually the kidney dysplasia is established during fetal life, so it's difficult to delay its progression, especially with antibiotics. Okay,
and then let me just step in here. During the consensus conference, have you discussed whether prophylactic antibiotic is indicated in some forms of CACUT? Was this part of the PICO question that you asked?
For us, no, because we are going to also write a consensus for the postnatal part of LUTO.
Okay. Okay. Same for you, Stefan?
Yeah, we that was not a main topic of our discussion at the meeting in Heidelberg. Yeah.
Okay, so Marina Shumikina is asking you First of all, she appreciated the webinar. Whether you think that it's necessary to prescribe nephroprotective therapy with an ACE inhibitor before macroalbuminuria in the presence of ultrasound signs of renal dysplasia or obstructive dysplasia?
So probably this question is for me. I would say no, because dysplasia is not a really, it's not a fastly progressing phenotype. For example, like Alport, we can expect that the kidneys will, the kidney function will decline, but this is different for Capone and for dysplasia. So I think we can wait for microalbuminuria to develop and then treat it. There's no reason to treat it earlier than that.
Okay, now it's for Valentina, the next one. The question is from Matsjad Kovac. When do you suggest to do a renal dynamics scintigraphy in LUTO? What are your experience with the nephrostomy tubes in LUTO? I'm reading the questions here.
Yes, so the consensus is about the prenatal part. So we haven't discussed these topics. I can give you my opinion. I don't have, I don't have expertise in nephrostomy because I'm a nephrologist. But I can tell you that usually the dynamic scintigraphy is performed after the PUVs ablation after birth, and then at 1 year after the intervention to see what changed and if the intervention was successful.
Okay, so Reza Fahtevi is asking a question to both of you. When is the best time to repeat the ultrasound after birth? So, Stefan,
you go first. Go.
Well, I am not sure if there is a, so speaking for kidney dysplasia, if there is a good time to do it, I would say whenever possible. I mean, these children are in the clinic anyway. I would just wait until the mother and the baby are stable. If the kidney function is not an acute issue at the time, at least, and then we can see whether there are additional Capones or other involvement of other organs. I don't think there should be a certain time when this has to happen. I think it can be flexible.
And for you, Valentina?
For me, if there is a suspect of LUTO prenatally, the first ultrasound has to be performed during the 3rd, 4th day after birth, but no later than the 1st week of birth. No, right away, we know after birth, because children are dehydrated, so you can underestimate a dilation.
Okay.
Of course, there is a very important megacystis right after birth. The urologist looks at the bladder and sees if there's something to do right away. Of course.
Obviously, you know, if you have oligohydramnios, you will just, there's no point in waiting, right? So, a question for you, Valentina, from Nathalie Godefroy. What is the cutoff of gestation to offer VAS?
Okay, so we've seen that the best results are if VAS is performed between 20 and 26 weeks of gestation, but I don't think there is a limit to do it. You can also do it later in gestation when it's more secure, of course, to perform VAS, because if you have a preterm labor, the child, the fetus is bigger, but also the results are less satisfying.
And also, you know, the more you wait, the less dangerous it is to have a preterm delivery. You know, there's a certain
yes,
point.
What I meant, right?
It's actually, you know, 32
Not
weeks.
at all.
You know, prematurity would be less dangerous than a VAS. You know.
Yes, but you have less satisfying results on development and kidney function.
So 20 to 26. Thank you. And the last question is for Stefan. Is kidney dysplasia correlated with the gestational age and low birth weight? The question was from Annie Puspitasari.
So actually, those are two questions, right? Gestational age. The question is, when does this phenotype arise? And because there are so many different etiologies behind kidney dysplasia, I cannot really tell that. But I think kidney dysplasia are probably hundreds of different etiologies. So they can arise at different time points. For example, aplasia is very early. Dysplasia can be later during nephrogenesis. So this is one part of the answer. And the other part is that, of course, the uterine environment can affect kidney development. We know that dysplasia is a multifactorial phenotype, and the mother's health affects kidney development. So yes, this can cause kidney dysplasia or hypoplasia, I would say probably more.
Okay, let me turn around the question just to try to interpret it. Do you have are there any data showing that SGA children are at higher risk of having kidney dysplasia, and are premature children at higher risk of having kidney dysplasia?
I have to say I'm not sure about dysplasia. I know that the kidneys can be smaller and there can be less nephrons. I'm not sure about dysplasia per se.
Okay.
I cannot answer that, sorry. Yeah.
No, but I don't have the answer to that either, but it's actually an interesting question, especially the SGA.
Absolutely.
There's been a lot of, and again, I would have answered the same way in terms of nephron number, but low nephron number and dysplasia are two different things, right? All right, okay, so I think we are at the end of the questions, and we are perfectly on time. So again, to both of you, thank you very much. It was very interesting. We had a good audience, and until next time. Stephanie, do you know which is the next webinar?
Yes, maybe Valentina can share her screen.
Yes.
I listed them.
Okay, so the next one is Haute Cervelle. That's a very specialized webinar. Adeline phosphorylglycerol transferase deficiency, an undiagnosed cause of renal failure. And then Francesco Trepiccione will talk to us to one of his favorite topics, glycogen storage disease 1B and 11, from the mechanisms of disease to novel treatments. And then Pascal Houillet will give us a talk on disorders of renal calcium handling. So for March and April, we're all set with very interesting webinars. Thank you very much to all of you. Thank you.
Thank you.
Bye.
Have a nice afternoon.
Thank you. Bye-bye.
Bye.